This is a Baggy Sisa podcast.
The first ADHD medication was registered back in 1937. We're approaching 100 years of treatment. It's well researched. It is safe in the correct patient. But like everything, whether you use a Panado or a Disprin or whatever the case might be, medication can have side effects. And it's also important to be informed about the type of side effects. The most common being appetite suppression, or if it's taken too late in the day, insomnia.
Hello and welcome to the second and last part of our podcast series on attention deficit and hyperactivity disorder, or ADHD as we all know it. In this episode, I continue to talk to psychiatrist Renata Schoeman. As many of you know, ADHD makes it harder to concentrate and control your emotions. In this episode, Renata will tell us how ADHD medication works and why it doesn't also help people without the condition to concentrate better. Renata is the co-author of South Africa's guidelines on how to manage ADHD and also serves on the Ministerial Advisory Committee on Mental Health. Renata, welcome back. Let's talk about treatment. It's relatively common to hear about school children on Ritalin or Concerta. Is it safe to use, and does it really help for ADHD?
I want to start with maybe saying, if you're skeptical about the medication, be skeptical about it and ask the right questions. Because there is unfortunately a lot of children, adolescents and adults that get scripts for ADHD medication that should not be on the medication. Either they don't have ADHD or they have other comorbid conditions where there is other alternatives we should use than the run-of-the-mill or the gold standard methylphenidate medication. However, if you or your child do have ADHD, the medication is very, very well researched. The first ADHD medication was registered back in 1937. We're approaching 100 years of treatment. It's well researched. It is safe in the correct patient. But like everything, whether you use a Panado or a Disprin or whatever the case might be, medication can have side effects. And it's also important to be informed about the type of side effects. The most common being appetite suppression, or if it's taken too late in the day, insomnia. But some patients, especially if they have underlying vulnerabilities to anxiety or mood disorders, the medication might aggravate it, even maybe only temporary. So that's why it's so important to speak to a psychiatrist that really knows the medication very well in terms of the different treatment options, to choose the correct medication for the correct patients, for the correct symptoms in the correct context.
How does the medication scientifically work? What does it do to your brain to help you to concentrate or regulate your emotions?
So again, Mia, it's important to know that there's different classes of medication. There's what we call the stimulants and there's the non-stimulants. In the non-stimulants, and I'm not allowed to talk brand names, but the active substance of the non-stimulants, the one that's best known as atomoxetine, but there's also some of the antidepressants, for example, bupropion, that works quite well. They do not have stimulant effect. They're mostly reuptake inhibitors, which means the neurotransmitters that your brain produce under normal circumstances are then prevented from being metabolized or recycled. That is the simplest way of explaining it. In other words, the neurotransmitters can just bind better to the receptors, and therefore there's a better action. The non-stimulants do not usually have the side effects of increasing anxiety, for example. And the non-stimulants, for example, the antidepressant group like bupropion, also have an added benefit that it also works in your limbic system to directly improve motivation and drive. If we look at the stimulant group, and in the stimulant group, methylphenidate is the one group, and the other group is the amphetamine group. Methylphenidate, people knows the best. There is short-acting, medium-acting, and long-acting, or long-acting and ultra-long-acting, depending on your classified. And all of them are also dopamine, noradrenaline, reuptake inhibitors in your frontal lobe. So it increases the release or the availability of noradrenaline and dopamine in that important areas in your brain for attention, concentration, and executive functioning. The amphetamine group, we have to understand that it's different from the substance of abuse. It's not the same when we talk about amphetamines. So we classify it as amphetamine, but it's distinctly different from a drug of abuse. In those, we have again two groups. in South Africa. The one is more directly what we call an agonist. It stimulates the receptors. And then we have a long-acting one that is a prodrug. So it's an inactive drug that you take, and it's metabolized in your bloodstream then to release the dopamine and the noradrenaline. Once again, you will hear dopamine and noradrenaline. And this latter group is a bit more potent in terms of how good it works, but in a way it's a little bit softer in terms of side effect profile. It also works on serotonin, which makes it a bit different from the methylphenidate group. And the serotonin there is important, as I mentioned earlier, presumably for the impulsivity and the emotional dysregulation that we see. There's not one of these drugs that is the go-to number one. And we feel strongly in South Africa that it shouldn't be an algorithmic approach, like first try this one, then try this one, then try this one. It should really be matching the correct patient with the correct medication and the correct medication for the correct symptoms.
Renata, so often we hear about university students who want to do better at university or want to be able to cram during exams. And then GPs just prescribe Ritalin for them and they believe they study better. Does it really work? And how do you feel about this abuse?
Big sigh. Number one, it doesn't really work. That is the irony of it. So there's very good studies that is recently conducted and published last year and the year before, especially in Australia, where they looked at what is the benefit of this type of medication in people without ADHD. And what they found on neuropsychological assessments, some of the studies found a 2% improvement. So neuropsychological assessments would be that long, in-depth assessments that an educational psychologist, for example, do. But a 2% improvement on that doesn't translate at all to a real-life improvement, an improvement on your marks. But what happens? The students, they take their Ritalin, which they bum from someone or get from the GP, and now they think, oh, I have my tablet in now, I must go and sit and work. And then they put in the effort, and then their marks are better, and then they think, oh, wow, this tablet is great. The tablet does make them more alert, but they most likely will get the same effect from taking quite a bit of coffee. But because you're more alert and because you know now I must utilize my time, now they put in the effort, now they see a difference and they think it's a medication. More recently, some of the research that was conducted, they did a very interesting, what we call the executive functioning task, where they had to solve complex problems. They found that people with ADHD using the medication was significantly better in decision making, quicker, more accurate. Those without ADHD, when they take the medication, they completed the task, but it took them longer. They didn't make that many mistakes, but they didn't really do better at all. They were just more busy. They were shifting options more to and fro, but there was no real benefit for them, but they were busier doing whatever they were doing. So we know that there's a type of a U-curve. If you overstimulate yourself, when you do not have a neurotransmitter deficiency, you can actually perform poorer. And that's the important message for me. And that is the one academic discussion to have about it. There is actually no benefit. By the contrary, it can make it poorer if you don't have the diagnosed ADHD.
Let's move on a little bit beyond medication. Are there things that you can do that makes your ADHD worse or makes it better? That's not medicine, but that's just general things like eating or exercise that you can do.
So food cannot treat something, but we all know that, especially in the youngsters, if you're going to give a youngster a high dose of sugar and a high dose of caffeine, they are going to be busy. It's always my bugbear at children's parties. Everyone complain about it, but yet we still give sweets and sugar and fizzy drinks. So we know that. And that is not necessarily only valid for someone with ADHD. It's valid for all children. And we also know that there's more and more articles published about the toxic effect of excessive sugar for your mental health in general and your brain health. If we look at exclusion diets, there is a certain group of patients that might have allergies or food intolerances where exclusion diets definitely help to alleviate symptoms. But in general, it's more doing the good things, do everything in moderation, avoid unnecessary stimulants and things that can affect you negatively and make you anxious, because anxiety also impedes ability to concentrate. Things that often make it worse is also substance abuse. So alcohol, and that general for your mental health is not good, but also it affects your sleeping negative. And sleeping is one of the most important things that we can do for our mental health, but also our ability to regulate our emotions and our ability to concentrate the next day. So sleep deprivation is a huge problem, and you definitely need to pay attention to your sleeping patterns. Together with that, one of the things that naturally can boost dopamine, so not only your motivation, your general sense of well-being, but also your ability to concentrate, is exercise. And for mental health, we always say 5 times a week, 30 minutes. I always say for ADHD, every day a little bit. But then the big problem we also see these days is excessive screen time. And excessive screen time, the first studies that appeared about the negative impact on the brain and the ability to concentrate and the potential to mimic ADHD already was published back in 2017, where we found that there's more intrusive thoughts, more distractibility, less ability to concentrate, more irritability. So excessive screen time is a massive problem, and I often have adults and adolescents in my practice that complain that they can't concentrate. And if we look at their screen time, they would be 11, 9, 13 hours a day on their screen. And I'm not talking about careers where you have to work on spreadsheets on your computer or code. I'm talking about people with mindless scrolling, TikTok, social media, doom scrolling, YouTube videos and clips. Those things are really, really detrimental to your brain. So it's so important that we learn to use technology to our advantage, but that we are still managing technology, and that technology is not managing our brain and cause a technological addiction, because that excessive screen time and the constant scrolling and change of our screen literally depress the dopamine in your frontal lobe, and then you cannot focus.
Renata, you've mentioned that for people with ADHD, it's often harder to survive socially, and that mental health challenges such as depression can often coexist with it. Does that mean, when they look at coping mechanisms, that if you, for instance, then don't treat ADHD with medicine, that you become more vulnerable to something like, say, substance use disorders?
Firstly, let's talk about the comorbidity in ADHD. Interestingly enough, in adults, the comorbidity is even higher than in children because there's a longer period of untreated conditions. But we know that up to 87% of adults might have one comorbid diagnosis, whether it's anxiety, depression, a sleep problem, a substance abuse problem, even an eating disorder or obesity. But 57% of patients have more than one comorbid condition. They are aware that they lose their train of thought, they're aware that they drift in conversation, that they might become anxious before a social conversation or before a meeting, and they might start using maybe alcohol as a crutch to just make them a bit more calm and not being aware so much of overthinking what other people say. What we also see, especially in women, but also in men, but more common in women, is that they become extremely strict and routinized and almost pathological perfectionism of what we call obsessive compulsive personality traits, where things need to be so routinized and structured that it is a coping mechanism, and that helps them to survive, especially the higher functioning women or more intelligent women. But it can make them more prone to anxiety disorders and to depression, but also interpersonal difficulties because of the high standards they might have of themselves and others.
How common is autism or conditions on the autism spectrum that co-occur with ADHD?
It is common. We know that both ADHD and autism is neurodevelopmental disorders, and it often coexist. I think people neglect the ADHD, and if you treat ADHD properly, and if you also support a child or an adolescent with social skills training, many of their social difficulties disappear, and many of their rigidity and difficulty coping with change disappear because they're functioning better. Except if the symptoms are very, very clear since toddler years or early attachment years that there's autism as well. I would always opt for treating ADHD first, treat it properly, and see what is left. If you treat the one that causes the most functional impairment, the other one symptoms might be so alleviated that it doesn't really say it's something that we have to diagnose.
Renata, lastly, you've mentioned that medication isn't always that accessible or help for ADHD. If there's one thing South Africa needs to do policy-wise to make that more accessible, what do you think that is?
Mia, it is always difficult to identify one thing that needs to change to really make a difference. But anything that aims at increasing accessibility to diagnosis and care would make a big difference. One suggestion is for early childhood identification and screening. We talk about child vaccination, but what about children's mental health? The second thing is definitely to look at accessibility to better funding, not only improving mental health care budgets, but specifically also the consideration of ADHD as a prescribed minimum benefit condition, which then by law oblige both the government and the private funders to make care, which includes both consultations but also medication, accessible and fund that for the patients, which then means better outcomes for all.
Renata Schoeman, thanks very much for sharing your time and insights about ADHD with us. Renata is a Cape Town-based psychiatrist. Thanks for listening to this episode. Until next time, cheers.
This was a Peggy Caesar podcast.